Choledochal cyst is nothing but a cystic dilatation of the bile duct. Okay. It is a cystic dilatation of the bile duct. Now, a few points for the basic understanding of the choledochal cyst. It is a congenital dilatation of the bile duct, and it can occur in the intrahepatic portion of the bile ducts as well as the extrahepatic portion of the bile duct. It is mainly seen in children who are less than 2 years of age, and it can be seen in adult patients also. Okay, and in children who are less than 2 years of age, it generally presents with jaundice or abdominal pain. The classic triad for choledochal cyst is palpable abdominal lump, jaundice, as well as abdominal pain. Okay, so this is the most common clinical presentation. There are certain complications which can develop inside this choledochal cyst, and there can be development of stones in the cyst. There can be development of cholangitis, blockage of the bile duct. There can be development of pancreatitis, or there can be development of malignancy of the bile duct or malignancy of the gallbladder or liver. Okay, and in few cases there can be rupture of the cyst also. Okay, this is the basic understanding regarding choledochal cyst, and the treatment is excision of the cyst in majority of the cases. Now I'll start. It is a congenital cyst or the congenital dilatation of the bile duct, and the most commonly approved hypothesis is APBDJ. Okay, now what is this APBDJ? This is abnormal pancreaticobiliary duct junction. Now, before that, we'll have to understand what is a normal pancreaticobiliary duct junction. So, see, this is a normal bile duct. This bile duct is joining the pancreatic duct like this, and then they are forming ampulla. Okay, this is CBD and this is PD. Suppose if this bile duct joins the pancreatic duct early, okay, then they become ampulla, then there will be a long common channel. Okay, there is a sphincter here which I have already told you. So this leads to reflux of the pancreatic juice inside the bile duct. Because of long common channel, reflux of pancreatic juice can occur into the bile duct, which leads to damage of the bile duct wall, and then leads to a cystic dilatation. Okay, now there are various types of choledochal cyst. This classification is very important, and the name of the classification is Todani's classification. We can remember it as Todani's modification of Elansolage classification. Todani's modification of Elansolage classification. It is based on the location of the cystic dilatation. So, the Todani's classification is actually a modification of Elansolage classification. It is based on location of the cyst. Okay, so it is mainly of 5 types. Type 1 is solitary extrahepatic cyst. Type 2 is extrahepatic diverticulum. Type 3 is choledococele or intraduodenal diverticulum. Type 4 is divided into two types, type 4A and type 4B. Type 4A is both, it's extra and intrahepatic cyst. Type 4B is multiple extrahepatic cyst, and type 5 is only intrahepatic cyst. So now we'll see here, if there is solitary extrahepatic cyst, then it is type 1. And if there is extrahepatic diverticulum types of cyst, it is type 2. And if the cyst is present in the duodenum or the intraduodenal part of the bile duct, then it is type 3, known as choledococele. And if there is both intrahepatic as well as extrahepatic biliary dilatation, it will be type 4A. So type 4A is both intra and extrahepatic. This is very important to remember. And type 4B is only extrahepatic, multiple. And type 5 is only intrahepatic. Okay, now what all are the most common questions which are asked? What is the most common type? Most common is type 1. Type 1 is most common type. Okay, and intraduodenal one is type 3, known as choledococele. Intraduodenal one is type 3, intraduodenal one is the type 3, also known as choledococele. Now both extra and intrahepatic is type 4A. Now how to remember? Type 5 is only intrahepatic and is also known as Caroli's disease. So Caroli's disease is type 5, in which there is presence of multiple intrahepatic cyst. Okay, and then multiple extrahepatic is type 4B. So these all are the questions which has been asked multiple times. Now another question, type 1 is the most common, followed by type 4, followed by type 3. So type 1 is the most common type. Okay, now regarding the treatment, suppose if this is a choledochal cyst here. Okay, now the treatment for extrahepatic choledochal cyst, treatment is Roux-en-Y, or you can say choledochal cyst excision with Roux-en-Y hepatococele. Or in short form, we can say it as RYHJ. Now, CDC is the choledochal short form for choledochal cyst, or CDC excision or excision of choledochal cyst with RYHJ, Roux-en-Y hepatococele. This is the treatment for any extrahepatic choledochal cyst. For intrahepatic choledochal cyst, the treatment is liver transplantation. And for intraduodenal one, or type 3, it is endoscopic sphincterotomy. Okay, so if we see now this thing, for type 1, the treatment, or for type 1, type 2, as well as type 4B, the treatment should be choledochal cyst excision and Roux-en-Y hepaticojejunostomy for type 1, type 2, as well as type 4B. For type 3, the treatment should be endoscopic sphincterotomy, and for type 4A and type 5, as there is presence of intrahepatic biliary radical dilatation or choledochal cyst, the treatment should be liver transplantation. So for type 1, type 2, as well as type 4B, the treatment should be choledochal cyst excision with Roux-en-Y hepaticojejunostomy. Okay. For type 4A and type 5, treatment is liver transplantation, and for type 3, the treatment is endoscopic sphincterotomy. Okay. Now, there is another new type of choledochal cyst which has been added recently here, and that is type 6 choledochal cyst. Type 6 choledochal cyst. This type 6 choledochal cyst is actually cystic dilatation of cystic duct. It is not in the classical Todanese modification, but it is recently added in whole lot of this choledochal cyst as type 6, that is the cystic dilatation of cystic duct only. Okay. Now, what all are the clinical features? The clinical features, it is characterized by a triad of abdominal pain, jaundice, as well as abdominal lump. Abdominal pain, jaundice, abdominal lump. This classical triad is seen in children only. It is generally not seen in adults. And overall, if we see, this triad is seen in around 20 to 30% of cases only. Okay. And the jaundice here is generally intermittent. Okay. So now, there is a young child. It is more commonly seen in young children. So if there is a child of 3 years, 4 years of age that is presenting with complaints of jaundice, abdominal pain, and there is a palpable lump in the right upper quadrant or right hypochondrium, then there is a probability of having a choledochal cyst. Now we'll go ahead and do MRCP, and this MRCP, in MRCP we'll be able to see choledochal cyst, and based on the type of choledochal cyst, we'll decide the treatment. Okay. Now, what is the most common symptom in children's less than 2 years age, or you can say in patients who are less than 2 years age? So the most common symptom is jaundice, and most common symptom in patient who is more than 2 years age, it is abdominal pain. Now, how to investigate? I've told you, investigation of choice is MRCP. How the choledochal cyst will look on MRCP? This is the classical picture of choledochal cyst. You can see here that so this is the bile duct here. This is the bile duct. Now this there is a cystic dilatation here. So this is something like this. This is cystic dilatation here. Then there is narrowing. Okay, and there is a pancreatic duct joining. So this is basically a type 1 choledochal cyst. Okay. Now, how the choledochal cyst is looking here. This is also a type of choledochal cyst. The CBD is like dilated. And here you can see that there is a cystic dilatation of CBD, and inside the CBD there is presence of stones. Okay, marked by the arrow, there is presence of stones here. That is cystolithiasis, or stones in the cystic dilatation. Okay. Now, what is this? This is basically the intrahepatic dilatation of the bile duct, and this is a Caroli's disease, or a type 5 of choledochal cyst. And what is the treatment? The treatment is liver transplantation. Okay, so this is very important, Caroli's disease. Now, what all are the complications or problems associated with choledochal cyst? Okay, so the complications can be development of stones, that is cystolithiasis, stones in the cyst. There can be cholangitis due to these stones. It can lead to pancreatitis also. It can lead to development of hepatopancreaticobiliary malignancies. Okay, and it can lead to development of any malignancy in this HPV tract. Suppose this is the HPV tract. It can lead to development of HCC, bile duct carcinoma or cholangiocarcinoma, gallbladder carcinoma, carcinoma in that cystic, in the choledochal cyst itself, pancreatic cancer, ampullary cancer, and duodenal cancer. So all these cancers can occur due to this choledochal cyst. That is why we are restricting the choledochal cyst. Even if it is asymptomatic, we are going ahead with choledochal cyst resection because it is a pre-malignant lesion. Okay. And among all the HPV malignancies, the most common type of malignancy that is seen in choledochal cyst is malignancy inside the choledochal cyst, is malignancy of bile duct. Okay, and what is the most common site is in the posterior wall of bile duct. Okay, now the investigation of choice I have told is MRCP, and the treatment is Roux-en-Y hepaticojejunostomy. Treatment is choledochal cyst excision with Roux-en-Y hepaticojejunostomy. Now, what is this Roux-en-Y hepaticojejunostomy? I'll explain. And suppose this is common bile duct here, and there is a choledochal cyst here. Now, what we are going to do, we are excising the choledochal cyst, and this portion of the bile duct is excised. Okay. Now, we are left with bile duct here. Okay. So now we are left here with the common hepatic duct, and we have excised whole of the bile duct. Now, we want to drain this bile, and to drain this bile, we'll have to use a loop of jejunum. Okay. Now, jejunum here, if we see, like from DJ flexure, if we start, there is a jejunum which is going. What we are supposed to do, we are supposed to transect this bowel and take it towards the bile duct and join this bowel to the bile duct. Okay. This way, what will happen in the final picture, that there is a common hepatic duct here, then there is a loop of jejunum here, and then there is a stapled end or cut end of the jejunum here. Okay, and this rest of the jejunum is going along with this limb. Okay, because we have divided these two jejunum, this jejunum we have divided here. Now there are two limbs here. This limb is going towards the bile duct, and the remaining of the rest of the intestine is connected with this. So whatever food the patient is eating is coming from the duodenum to the DJ flexion and then in the proximal jejunum. Now we'll have to connect this proximal jejunum here to this limb, to the roux limb. Why? Because whatever the food the patient is saying, we want to restore the enteric continuity. Okay, so this jejunum will be connected here. Okay, so whatever food the patient is taking will go inside here. Whatever the bile from the CHG is coming will go from here. So why we are doing here, why we are making a Y kind of a configuration? Because we don't want the food material to reflux here inside the bile duct. Okay, to avoid reflux cholangitis, we are making a roux limb. Roux limb is made. Okay, that is why we are making a configuration like this to avoid reflux cholangitis. Because we want to avoid reflux, this roux limb should be of a particular length. Okay, and the length is 40 to 50 centimeters. At least the roux limb or the bypass limb should be around 40 to 50 centimeters.